So, Dr. Venkatesh will be speaking about pediatric cataract concepts and consideration. Over to you.
Thank you. Shall I start?
Yeah.
Very good afternoon to you all, to all the learned audience members and our faculty, and all my dear chairpersons. Today I shall be talking about pediatric cataract. I have no financial disclosures to make. Before I begin, I would like to pay a big vote of thanks to my mentor, Professor Sudarshan Khokar. Most of the work which I'll be discussing today has been derived from his book, Atlas of Pediatric Cataract. So we know it's the incidence is around 1.8 to 3.6 per 10,000 per year. And in the studies which have been done at our center, which is RP Center, developmental and post-traumatic cataracts are quite common. In one of our studies, we found that the developmental cataract incidence was actually more than the post-traumatic ones. Genes which are usually involved are alpha-crystalline, PAX6, PITX3, and the most common inheritance pattern noted was autosomal dominant. These are few pedigree charts of the same, and I shall directly come to the morphology. There's a morphological classification as well, if it involves the whole lens, whether a lamella, it's a central cataract, or anterior, or primarily posterior, or miscellaneous. And here I'm showing you certain clinical pictures along with the associated UVM findings. Here you can see in picture A, there's a total white cataract and the associated UVM. In picture B, there's a Morganian cataract. You can see the sinking nucleus here as well in the UVM. In picture C, the lens volume has been lost because of egress of fluid from the microleaks, and you can see it's a membranous partially absorbed cataract. This is a lamellar cataract. This is a nuclear cataract, pulverulent or powdery cataract, ant-egg or cataract with calcific foci, cerulean cataract, sutural cataract like an inverted Mercedes-Benz sign, and other miscellaneous classifications like anterior polar, anterior subcapsular, posterior polar. These are all different kinds of cataracts which we have rarely encountered in our practice. This is a typical barbed fence wire-like cataract, though these are quite uncommon. The etiology, most of them are idiopathic. Hereditary causes include Down syndrome. These are few other ocular features like brush field spots which can be noted in them. Loewe syndrome is also associated, Nance-Horan syndrome, where we see long rectangular faces. Alport syndrome associated with anterior lenticonus, and Marfan syndrome. It's usually associated with subluxation of the lens with increased arm span, pactus carinatum, aortic root dilatation, high arched palate, long slender fingers, and revised Ghent criteria has been used to diagnose Marfan syndrome. Galactosemia is associated with oil droplet cataracts. Homocystinuria again is associated with lens subluxations and myopia. Wilson's disease with sunflower cataract, and infectious causes which are quite common in our country, torch infections, the most common of which is congenital rubella syndrome. We see typically these kids with microcephaly, microphthalmos, iris atrophy, polydilating pupil, and partially absorbed cataractous lenses. Anterior segment dysgenesis in the form of Peters anomaly is also noted to have these cataracts. Other morphologies and other causes include pre-existing posterior capsular defect, persistent fetal vasculature, which is a common cause of unilateral cataract, traumatic cataract, and uveitic cataract. Pre-existing posterior capsular defect is noted in cases of posterior polar cataract, PFV, and lenticonus. You can see here that there is a peripheral white dot sign because of the egress of the fluid and then rapid maturation of cataract. This is typically called as the white dot sign. You can appreciate the UBM of such a case where the lens is almost absorbed and there is a posterior capsular defect and there is lenticular matter in the anterior vitreous. Persistent fetal vasculature is actually a spectrum ranging from persistent pupillary membrane, mitten of dot, cataract, to vessels over the lens, and then posterior PFV includes Burgmeister's papilla falciform fold. Traumatic cataract can be due to open globe injury or closed globe injury. Uveitic cataracts are usually associated with juvenile idiopathic arthritis. They have other associated features such as posterior synechiae, band-shaped keratopathy. So how to approach these patients when they come to our clinic? We have to take a detailed history. The parents usually give a history of inability to make eye contact, squeezing of eyes, especially in bright outdoors, squinting of eyes, and abnormal ocular movements. Especially if the kids are older, they give a history of inability to read the blackboard, bringing objects too close to the face, or sitting too close to the television to watch. And general examination is very important. As we have seen, there are certain metabolic causes associated with these cataracts. Like this is a case of microcephaly seen in congenital rubella syndrome. Leukocoria, whenever the kid presents, we have to keep other differentials in mind as well, including retinoblastoma, PFV, ROP, and Coats disease. And examination includes primarily doing a distant direct ophthalmoscopy first, having a good vision good assessment of the red reflex. Visual acuity assessment has already been discussed in detail. Pupillary examination, very important, though very simple and old test, but works well because it tells you about the optic nerve health status. A Bruckner's test or a red reflex would give you idea about the opacity, as you can see here. Fixation, very important. In pre-verbal children, a central steady maintained fixation can help you give a prognosis to the parents. If it is non-central, unsteady, not maintained, the prognosis will be guarded, and you have to tell the parents that despite the surgery, despite long follow-up, the kid may not gain vision beyond a point. Vision tests in infancy have already been discussed. We have been routinely using Cardiff visual acuity charts, which are preferential looking tests based on vanishing optotypes at our clinics. And more than 1 year of age, primarily these are candies and balls, the smallest of which a child can pick up, gives us an assessment of the visual acuity status of that kid. Ocular examination on the anesthesia table is very important because here we are doing the biometry. A scan, B scan, MRI, especially in cases of PFV cases. Here you can see a PFV stalk associated with a color Doppler showing the vasculature, and the MRI associated with the same, where you can observe that the globe is shrunken. It's a microphthalmic eye. You can see the PFV stalk as well. Laboratory investigations become quite important in conditions such as galactosemia. So it's a multidisciplinary approach. If a Marfan's patient comes to you, we have to send it to our cardiovascular colleagues. If a GIA patients come to you, we have to send it to our rheumatology colleagues. In GDD patients, peds neuroconsult becomes important. There have been a lot of talk about emmetropization, so I won't be covering that part, and change in axial length, which is attained to the adult level by approximately 5 years of age. So it's all a very organized process where there is increase in radius of curvature, increase in anterior chamber depth, and thinning of the lens. And simultaneously, there is an increase in axial length. Whatever opacity or any disturbance which causes disparity in this balance will lead to hyperopia or myopia. And active emmetropization also occurs because of feedback from our image clarity from the retina. So, examination under anesthesia. Smaller eyes, we should not put IOLs in such spaces. We have our own cutoffs. I will tell you about the same. Keratometry is very important, which should be the first step in the UA before we put anything over the cornea. Do not use a speculum, use a handheld keratometer. Axial length measurement, immersion A scan are the best. If not possible, you can use a contact A scan, but don't indent too much. Otherwise, you will be having axial length which is too short. Ultrasound biomicroscopy, if you can't afford, don't worry. It's a very good tool which helps you prognosticate, especially in cases which is having a posterior capsular defect. But clinical examination like a deep anterior chamber, white dot sign will also give you a clue about how to proceed with such a case. This is our UBM cups. In a water bath, we put the UBM probe and assess. It also gives us an idea about the white to white. Depending upon the white to white, we can actually determine whether we have to put an IOL or not. This is a UBM of a cataractus lens. And again, I'll show you a partially absorbed cataractus lens where most of the lens matter is reduced. There can be a posterior capsular defect. So we may have to use a multi-piece in such a case. I cannot proceed. Can you help? Yeah, I'll just take 2 minutes. Preoperative considerations and surgical planning. So we intervene in such a case when there is a visually significant cataract more than 3 mm obscuring the visual axis. There are abnormal ocular movements in the form of nystagmus or nystagmoid movements, squint and obscuration of globe with a direct ophthalmoscope. A poor near vision is also a very good indication to operate and go inside these eyes. Timing of surgery is very important because there is a critical period of neuroplasticity after which amblyopia sets in. Unilateral cataracts operate as soon as possible, 4 to 6 weeks of age. Bilateral cataract at 6 to 8 weeks. But the problem is not the timing of surgery. The problem actually is the age at presentation by which the parents take the kids to you. Our cutoff at RP center is axial length more than 17 mm and white to white more than 10 mm. We proceed with the IOL. And there have been undercorrections described by Dahan, Prost and NERD. We use our own nomogram, less than 6 months of age, 20% undercorrection, 6 months to 1 year, 15 to 10% undercorrection, 1 year, 2 years, 5 years, then 2% undercorrection. Choice of the IOL, hydrophobic square-edged optic as far as possible. And for optic capture, you can use a multi-piece. There was a study of unilateral cataract done in US in which they tried contact lenses versus intraocular lenses. Their profile was different, and they also excluded cases such as PFV, which is quite a significant proportion of our unilateral cataract population. They found that putting a lens before a certain age might lead to secondary complications like secondary glaucoma. But the thing is, in our population, most of the patients are from poor socioeconomic strata, consanguineous marriages, and they are not that educated as well. So putting an IOL might be a good option if they are not very compliant with spectacles and contact lenses as well. There are certain surgical challenges we have to keep in mind about the head position. We can use a shoulder roll and a head ring and appropriate size speculum, proper incisions, CCC runs off, so we have to use a heavier viscoelastic like a Helon GV. Anterior capsule management, as I told you, heavier viscoelastic than multi-quadrant hydro. And for posterior capsular access, a very important step, we do not need to fill the bag, just the anterior chamber, adequate enough to create a space for our ILM forceps or whatever forceps we used to go. It should be smaller than the anterior capsular axis, and an anterior vitrectomy is must, because if we do not cut this anterior vitreous, this can act as a scaffold for PCO formation. Our cutoff for doing a CCC is 7 years of age, but let's say if a kid of Down syndrome is there, if a GDD patient is there who cannot sit on YAG later, you can do a PCCC even after 7 years of age. IOL implantation should be against the anterior capsule in the bag, and incision closure with 10-0 is very important, and it is a low scleral rigidity tissue. We do the suture removal at 6 weeks, and post-op refractive correction with glasses is given. Less than 2 years of age, we give prescription for near. After 2.5 to 3 years of age, when the kid goes to the playgroup, we can prescribe for distance with a near ad. Executive bifocal is good in such cases. And in unilateral cataracts which have been operated, there is already a component of amblyopia, so we need a age-appropriate patching. In cases of severe amblyopia, full-time patching. In case of mild to moderate amblyopia, partial occlusion may be fine. So to sum up, PCO can be a complication which needs to be catered with PCCC. Early identification and early surgical intervention is must in this patient. IOL implantation in Indian setting does have a key role. PCCC less than 8 years of age is very useful. Suture placement, because the tissue is very elastic and having less scleral rigidity. Refractive correction, regular follow-up is very important. Amblyopia therapy and management is key. And regular follow-up. The surgery per se is not the job. The job is the follow-up. And parent counseling before the surgery, that the kid would require long follow-up. There might be a need of research in the form of a membranectomy if VAO develops, or IOL exchange later if there is a refractive myopic surprise when the kid turns old. And there are certain post-operative complications as well, like VO and glaucoma, which should be managed appropriately. So I thank you all for your kind attention. Thank you so much.
Thank you for a very broad, elaborative talk.
Yes, ma'am.
Just one thing, you had written VP. So in which cases do we routinely do a VP in all cases?
No, we do not do routinely VPs.
So where in which cases are you actually asking for a VP?
Cases of long-standing RDs. There are a lot of patients which come after ROP with secondary cataract. Patients with long-standing RDs in which there is no visual potential. If there is a high with high hypotony, we would like to do a VP to know whether there is any prognosis or not. If there is no prognosis, there is no point in going inside that eye and let the eye go into phthisis eventually, or maybe not having any prognosis at all.
Okay. Also, knowing that you have a RD and it's a long-standing cases, so just to prognosticate those cases, you will be advising. But usually it may not help also if you...
Yes, ma'am. And it's not easily available as well.
So that point I just wanted to clarify, because
Yes.
Routinely none, even if you have a RD,
Yes,
also
ma'am.
there is not
It's
a
just-
must that you can,
it's
you
just for
needs
an-
to be
it's
done.
just for
Yes,
a-
for a documentation, for something you can ask for it, but already
not for
the
routine
prognosis
cases.
is...
It's just an add-on for such cases.
Yeah.
Thank you. Thank you for your kind listening.
Thank you.